Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Sallallahu wa sallam ala Rasulullah. I'm going to talk about the neonatal skin rash. So the first case, 48 hours old, female, infant with this rash. This is a second rash. Otherwise, baby clinically looks well, feeding well, active. Differential diagnosis, or what's most likely cause? Erythema toxicum. Good. So erythema toxicum neonatorum, it's very, very common. It's up to the 50% of infant. It's considered one of the most common, or the most common vascular eruption rash in the newborns. Usually presented around 2 to 3 days of life, but can be even presented at birth, and usually disappear around 1 week of age, but can be last longer. The clue, Bowman sauce does not involve it. Also the clue in the physical exam that the baby completely well looking, asymptomatic, and the most important clue, the eosinophilia on your vascular smear. If you're gonna take smear from the pustules, it's revealed even eosinophilia. So I can see erythema toxicum, although the name is toxicum, but when you take the smear, you send for the lab, it appears as a eosinophilia. So 3 important notes. Number 1, baby asymptomatic on the physical exam. Number 2, it's appear around 2nd, 3rd day of life. The third clue that Bowman sauce is not involved, and as you can see the description, it's the erythematous babular or babulobascular rash. Okay, very good. Second, 24-hour baby or just baby after birth, they call you a delivery room, or shortly after delivery room, they notice to have the vascular rash in these pictures. Another picture, and that's the typical picture, full picture. You can see there is pustules here and some macular pigmentation. What's your diagnosis? Yes, transient neonatal vascular melanosis or vascular melanosis. So that's the very, very common. Also transient neonatal vascular melanosis. So another self-limited dermatosis of unknown etiology, usually common in the black male. The clue, number 1, baby born at birth. So that's the first clue, is the present at birth. The second clue, the description of the rash itself as an erythematous pustule, and then later on, or in the description itself, it's when the pustule ruptures, is remain pigmented macules. So that's the third clue. The fourth clue, when you take the smears, it's appear as a reveal neutrophils. Okay, that's usually this hyperpigmentation lasts 3 weeks to 3 months. Okay, so first 24 hours of life, neonatal vascular melanosis. After 24 hours of life, you think of the erythema toxicum. Okay, very good. This baby, very common rash. We see it during neonatal period, first 24 or 8 days of life or 1 month of age, and usually it's on off, and that's called, yes, cutis marmota or mottled skin. Usually transient, net-like, red, blue, mottled. Most likely is response to the cold weather or warm. So it's a vascular vasoconstriction secondary to the cold, or usually secondary to the cold. Before you make this diagnosis, very important to look at the baby. Is baby you look sick looking? If the baby is sick, it could be related to the sepsis, yes, which is when you have a sepsis, usually baby have the vaso or defect on the capillary filling times, and usually baby is very sick. Vasoconstriction because of the septic, depending on the how degree of the sepsis, but can be baby cold extremities, and you can have mottled skin. But the baby look well looking, usually it's benign and resolved by rewarming. If your rash persists past 6 months of age, then think of the hypothyroidism. You need to screen for the hypothyroidism, okay? Another conditions you can see, hyperpigmented macules with hairy. There's another picture of different babies. Do you think this benign condition? Does this baby need referral to a dermatologist? The answer is yes. So that's the congenital melanocytic nevi. So melanocytic nevi. It's precancers. There's 2 to 10% lifetime risk of the melanoma. Whenever you see this kind of rash, always think of the melanoma, okay? So that's the melanocytic nevi, usually hyperpigmented macule or plaque with the dense of hair growth. There is a small chance that this baby maybe later on, he or she might develop melanoma. Those cases, if it's very big, a small area, usually of close observation. If it's very big, then full thickness excision, followed by the graft. Okay, that's very common. You can see, what do you see on the Bowman salts? Blue, correct? So what's called acrocyanosis, yes. So that's very common, usually on off. You see it a lot during the baby who just born, resolved by the warming the skin, okay? Let's talk about hemangiomas. What kind of hemangioma is one? So we have strawberry hemangioma, we have the Sturge-Weber or salmon patch, we have the cavernous hemangioma, we have the port wine hemangioma. So these conditions, what do you think? Another picture. So this one is the strawberry hemangioma. Why? It's superficial, infantile strawberry hemangioma. If you're gonna go back to this one, you can see it's raised skin or flat. You cannot see any deep structure. So everything is here looks normal. So there is no bluish discoloration. You cannot see anything beyond just on the superficial skin. And this one is very, very, very board exam question. It's occur on all 10% of all newborns. It can appear everywhere or anywhere, most commonly in the face, scalp, back, or chest. This one may present, may be absent at birth, but usually shortly after develop, and the characteristic history that rapidly growing in the first 6 to 12 months before plateau and then slowly involution. So you have to prepare the parents that are getting bigger. Don't get panic. That's very common. That's the natural history. Is going to get bigger before it gets smaller. Okay. If they ask you how long it's going to take, is it last? It's depend, but the majority around 10 years of age. Do we need to refer them? Usually no, unless it's multiple. We will talk about it more later on. There's another child with another type of hemangioma. As you can see, if you look at just this, it looks like strawberry, but you can see also there is bruises or bluish discoloration, and you can see this hemangiomas come from the deeper structures. Okay, another picture, you can see there is bluish and come from the deeper structures. So that's called cavernous hemangioma. So cavernous hemangioma is more deeper situation. Okay, majority of this lesion may disappear on own, and usually around school age. If it's in very sensitive areas or very big, might need steroid therapy or surgical intervention. If it's multiple, we might treat it with propranolol. What I need you guys to pay attention, rather than knowing that's cavernous hemangioma, also you need to recognize it if the hemangioma associated with thrombocytopenia, especially, is very big, we need to rule out Kazabech-Merritt syndrome, a rapid growing hemangioma plus thrombocytopenia. Again, rapid growing hemangioma plus thrombocytopenia, rule out Kazabech-Merritt syndrome. The third type hemangioma that's very, very, very common, benign condition, either on the back, stroke bite, or on the face, and it's increased when the baby or crying. That's Thalhamon batch, okay, or stroke bite. Almost seen in 60% of infant. Usually take around a year and completely disappear, okay? That's another interesting type of hemangioma. You can see one side of the face. What kind of syndrome I need to rule out? What are you gonna tell the parents? Does the baby need CT scan or MRI? So this one is port 1, stain, good. Syndrome associated with, we need to make sure that we remember Sturge-Weber syndrome. Okay? Sturge-Weber does all port wine associated with Sturge-Weber? No. So Sturge-Weber syndrome is a condition when you have hemangioma involved with the third trigeminal nerve plus seizures, glaucoma, CNS effect, hemangioma, and then when you do the CT scan finding, you will see the TRAIM line or TRAIM cortical calcification. So that's the called TRAIM cortical calcification. You can see on the regular X-ray, or you can see in the CT scan without contrast, TRAIM calcification. That's the characteristic, or that's the clue, okay? So port wine can be anywhere. If involved with trigeminal nerve or the fifth cranial nerve, then you need to rule out Sturge-Weber syndrome. It's a condition where you have more than just port wine hemangioma, seizures, CNS involved with hemangioma or mental retardation, glaucoma. So those babies, you need to refer them for the eye exam to rule out glaucoma. Does all babies need CT scan? No. These babies need to follow up, and then if he had any of this, as long as clinically he looks completely fine, there's no neurological deficit, then just need you close follow up with the dermatology or with the primary physician. And then if he has any neurological finding, then you need to do the CT scan. So routine CT scan, at least by the AAB, is not recommended. So which condition I need to refer to the dermatologist? Number one, if there is involved the very mucous membrane in the face, in any mucous membrane area, around the eyes, nose, mouth, those is the dangerous places of the hemangioma. Then you need to around the eye, on the nose, lip, or large portion of the face, then you need to refer to dermatology. If they're involved in the lower spine, also you need to refer to the diaper area. That's another condition. We will see it later on. If multiple hemangioma, usually more than 10, or you're not sure about the diagnosis, then feel free to refer to the dermatologist, okay? So that's the condition where the port wine hemangioma that involved on the lower extremities and the half of the lower extremities and the lower spine. This you need to, when you see this one, you need to make sure that it is not associated with the Klippel-Weber syndrome. Klippel-Weber syndrome, which is condition where the hemangioma associated with overgrowth of the whole structures, blood vessel, soft tissue, and bone. Okay, in the lower extremities, you can see the legs is the either unilateral or bilateral, depending on the condition. If the port wine involved the diaper area, make sure this baby need the ultrasound hip to rule out spina dysmorphism, okay? Or dysmorphism, or occulta spina bifida occulta. So just make sure the spine completely fine. So you need to send them for the hip ultrasound. Or sorry, not hip ultrasound, spinal ultrasound. Okay, so we finished the hemangioma. That's another case. A baby who just born with this kind of rash. on the face. Otherwise, baby looks clinically well looking. There is no history of the mom was completely insignificant. So that's the acne, correct? Yes. So neonatal acne, it's around up to 20%. It's reflect to the maternal cause. Second to the maternal hormones, okay? Usually take 1 to 3 months and does not need to resolve and does not need any treatment. Another case. Is it Milia? No. This one sebaceous hyperplasia, okay? Sebaceous gland hyperplasia. What's the difference between this one and the Milia? We will talk about it later on. But sebaceous hyperplasia, it's the yellow papular over the nose and the cheek. Usually, it's more yellow than Milia. So that's the first clue. It's more yellow than Milia. And also, second to the maternal or endogenous androgen stimulation of the sebaceous gland, and take 4 to 6 months to completely resolve. Versus is more white, that's called Milia, and distributed different. Okay, so barely yellow papule, usually in the face, up to 50%. It's the keratin-filled sebaceous or epithelial cyst. So it's already keratin-filled epithelial cyst versus sebaceous hyperplasia. Okay, which is related to the maternal or androgen stimulation. Next, are these rash the same? I remember when I start as a first month neonatologist, as a neonatologist, they called me because the baby was in incubator, and on the back of the baby, you can see this kind of like the rash is very clear rash, fluid cysts, or the very bright crystal-like. What's this diagnosis? Miliaria. There is 3 types or 2 types of malaria. There's Miliaria crystallina, the first image here. That's called the crystallinous crystals. And usually malaria in overall is the obstruction to the flow of the sweet gland, rupture of the sweet gland. Usually either on the scalp, face, back. Crystalline, usually it appears as superficial 1 to 2 millimeters vesicles. On non-inflamed cyst, you can see skin, so you can see it is nothing, there's no redness around it, just clear crystals. Versus Miliaria rubra, which is we call the baby's response to the heat, and usually around the neck, it's red papular or vascular rash, and both of them related to the temperature regular stress, and usually when you adjust the temperature, it's going to go away. Okay. So next case, when you have this baby who's just post-cooling, he had a history of hypoxic ischemic encephalopathy. You examine the baby off cooling, you found there is firm nodule in the subcutaneous tissue under the skin, redness. The nurse or the mom, she asks you, what's this? What do you think? And what's the differential diagnosis? Good. So this one's subcutaneous fat necrosis. So subcutaneous fat necrosis is very, very common, especially after the usually difficult labor, cold stress, perinatal asphyxia. This is usually asymptomatic, just in case you have a condition where the baby have a kidney issues, then you need to monitor the calcium level once or twice for risk of hypercalcemia. Although this complication is rare and can be potential lethal, but if baby completely stable, may just one time look at the calcium level, otherwise you don't need to monitor closely, okay? Subcutaneous fat necrosis. Okay, another case. Just focus here. I'm going to show you another one. Another one. So you can see it's 3 different, but this one is kind of looks like mottlet, correct? Involved with one side. Congenital maromata. So it come from the cutis maromata telangiectasia congenita. So cutis maromata telangiectasia. We just had a baby who sent home, born with these conditions, involved with only one leg, called congenital cutis maromata, which is mottless skin telangiectasia congenita. So that means there is telangiectasia congenital baby born with these conditions. Usually it's vascular, rare congenital vascular malformation. That term, as I said, came from the mottled skin. Its type congenital means baby born with telangiectic variety characteristic. That's a typical characteristic, and affected either leg or arm. But also trunk can be involved. Face, it's very rare. This condition, you need to make sure that does not, the parents explain to the parents that they have to be careful, they have to watch it. There is risk of the ulceration and through the pressure, necrosis, or it's going to be ulcerated or can get infected. The resolution usually within a first year of life, but this can be last longer, and there's potential risk of the ulceration, as I said. You need to make sure that is not part of the syndrome, like Adam and Oliver's syndrome. So cutis maromata is just telangiectasia. It's congenital. It's not changing with the. It's persistent. It's not like the mottled skin changing with the cold. This one is congenital. It's the staying all the time. Usually one side of the body, either arm or leg. There is a risk of the ulceration. Reassure the parents. Long-term follow-up. Genetic, you might send the microarray, make sure it's not part of the syndrome. Okay, so I need you guys to pay attention to this spot. Yes, sebaceous. Nevi or nevus. Sebaceous, nevus. Another conditions you can see it looks like sebaceous. Yellow, you see? It's yellow, orange, waxy lesion that present on the face or scalp. It might get longer and more wart-like during puberty, because this sebaceous nevi is very sensitive to the androgen produced during puberty. Usually benign, and observation through life is recommended. The reason why, it's precancerous. A few conditions can change to the basal cell carcinoma. If it gets very big, large, especially during puberty, then surgical removal it's considered, or elective removal. It's considered at the time during puberty because just hormones, so you need to prepare the parents that this might get bigger, especially during puberty. Also, you need to make sure that they follow long-term with either pediatrician or dermatologist for the risk of the basal cell carcinoma in adult life. Okay. Next case. This can be unilateral, can be one single, can be multiple. If it's single, it's benign condition. If it's multiple, you need to rule out condition like neurofibromatosis. That's cafe au lait spot, correct? Cafe au lait spot. And if it's 6 or more and larger size, then you consider neurofibromatosis. Another case, you can see What's this? Forceps delivery, correct? Or forceps mark delivery. Another condition, what do you think about this? And you can see bruises here. If you see it, that's the vacuum, correct? Mark. Okay. Common in African American, what do you think? Mongolian spots, correct? Good. It can be different location, different shape, some more dark than others. So that's called Mongolian spots. Scrotum is the most common affected area. Usually no need for observation. It just reassures the parents. This condition might completely disappear by the age or by the time. Few conditions that might not completely disappear, okay? So education. What do you guys think? Yes, post state, you can see dry skin, that's indicated post maturity, which is normal peeling. Okay. Look at here, the skin is completely normal, just dry, but there's no erythema. And we will discuss about the different later on. What do you think about this? And then what other conditions that you need to make sure that's not part of syndrome? Aplasia cutis congenita. Aplasia cutis congenita, aplasia cutis, or aplasia cutis congenita. Okay, so what do you see here? You can see that piece of skin is missing. It could be isolated finding. It could be part of the syndrome. Trisomy, one of those syndromes. Okay, it can be any syndrome. Especially trisomy 13, you need to be, but other syndrome like 4q deletion, epidermolysis bullosa, ectodermal dysplasia, Adams-Oliver syndrome, or amniotic fluid bands. The most important to rule out the other condition, you need to take a good history from the mom because the cause could be isolated. It can be unclear, idiopathic, or it could be multifactorials. There's contributed factors like drug, metamethasone, carbimazole, phalloboric acid, or trauma, or the amniotic fluid band. It can be also inherited, as it could be autosomal dominant or autosomal recessive. As I said, you need to make sure you send a microarray to rule out trisomy 13 for trisomy, so you can see chromosome analysis, or you can see just a microarray for plea deletion syndrome, epidermolysis bullosa, and etc., etc. Usually the prognosis is excellent. You want to make sure only supportive treatment required to the lesion. Okay. Make sure that infection is the most risk. So this area is open. There is risk of the local infection, meningitis, or sagittal sinus thrombosis. Okay, now we finished the benign conditions. Now we're gonna go for the more rare abnormal dermatological rash. You can see this peeling, but you can see this peeling, when the peeling it happened, it left red skin. You can see the peeling is off, and you can see area of the skin is very red. Ichthyosis, correct. So whenever who said ichthyosis, excellent, excellent, excellent. Okay, so those babies need to transfer to the NICU for further evaluation. Moist skin, that's the most recommended area to keep the skin moist. So those babies, at least short term, they need to do the transfer to the NICU, and then need humidity and fluid management. Another conditions or another case? Bolus, yes. No erythema around the bolus, excellent. Epidermolysis bullosa, good. If it's the erythema, there's golden yellow, then you think of the staph or strep. So the rare congenital anomalies, skin fragile. It could be 3 types: epidermolysis bullosa, or either epidermolytic or junctional or dermolytic. How do you differentiate between 3 of these? By the histological biopsy and send it skin biopsy. That's the only way to differentiate. Okay. Prenatal diagnosis now possible for number of variation, and usually treatment, supportive treatment. That's spot question. Another case, spot diagnosis, and you can see it's the lining, usually X-linked. Yes, Incontinentia pigmenti. So it's X-linked dominant, lethal in the male. It's part of the neurocutaneous syndrome. It has phases, usually patch of erythema, blister, follow the line of the Blasco, and then change to the warty, and then later on become pigmented. Increase pigmentation before they become hypopigmented. If you have these conditions, you need to make sure that every system should be involved with CNS, eye, heart, skeletal, dentist. So all the systems should be involved. Another condition for the board review. This baby born with, you can see sniffy, can be early or late. Majority of these conditions, you can see this combination involved with bulmosols. That's very contagious when you see it. Gamma. So that's called syphilis, congenital syphilis. Excellent. Congenital syphilis could be early, it could be late. If late, you can see the Hutchinson teeth. So usually secondary tribanoma, belladoma, spirochete. Symptoms usually appear around 3 to 4 weeks of age, but can be later on. The symptoms include rash, fever, meningitis, very sick babies, anemia, hepatosplenomegaly, jaundice, and etc. But the most characteristic that I need you guys to know, this combination of the skin, Palman soles. Diagnosis, serology test from the blood and from the CSF. So you need to do lumbar puncture. And treatment with penicillin, high dose. What's the diagnosis? Blueberry, correct? So blueberry rash, it could be, doesn't have to be rubella. So blueberry rash, can be rubella, it can be toxoplasm, it can be cytomegalovirus, it can be herpes, it can be varicella. So it can be any, okay? So torch, usually present with, or it can be blueberry muffin, any of these conditions. If they give you clue in the exam that heart involve cataract, congenital heart, PDA, then you might think of the congenital rubella. All right. So this is the hand, but usually doesn't appear in the hand in neonate, usually in the scalp. But you can see is the erythema around, vascular erythema. So there's erythema, vesicles, and then there is around it redness. So that's typical vesicles. So herpes. See here, that's very characteristic. And that's the herpes. It can be others, but most likely I will admit the baby because of the herpes. This contact isolation. Baby need to start on the therapy. We need to send the skin biopsy or skin culture, not biopsy, skin culture, and you need to send the PCR from the lesion and from the blood serum. Okay. And don't wait for diagnosis. Start acyclovir as soon as possible. I think the last, or not the least, another blueberry or muffin blueberry, you can see, but later on or can be born with atrophic. So that's the characteristic of varicella, okay? So early exposure in utero in first trimester can lead to the neonatal varicella syndrome. And the characteristic, and you need to pay attention to the linear scar formation. So that's called linear scar. So that's the scar formation. Okay. The others, pneumonitis, encephalitis, berber with hemorrhage, hypotension, death, or septic to the point to the baby, septic shock and death, that can be any one of these. Newborn at risk, you need to consider varicella zoster immunoglobulin or IVH. Start with acyclovir as soon as the suspicion of acyclovir raised. The last case is the mom born with condition, congenital, or she has something that the baby born with, either like you can see, annular rash, or he might have heart block, those baby at risk of heart block. What's the diagnosis? Lupus, correct? So annular erythematous plaque, you can see it's there with central clearance. Central clearance. That's the annular erythematous plaque, very rare conditions. Make sure that the moms, it's there usually, especially if the baby born with heart block or this rash, you need to look at the mom history and especially the anti-SSA or anti-RO or anti-LA. Because that's the only antibody that cross placenta and cause the baby's condition. And this baby, as I said, at risk of the heart block. Majority of the lupus, except for the heart block involved, usually resolve within 6 to 12 months. This baby might need steroids. Rarely required systemic. Okay, so by reviewing all these cases, we went to the neonatal rash, common newborn neonatal rash, and then I cover majority of the rare neonatal rash. Hopefully this is helpful, and the goal is to cover most of the board required questions for the dermatology. And if you guys have any questions, feel free to email me or send me on my email, aymanbenayad@gmail.com, or text me on the Facebook group under my name, Ayman Ben Ayad. Thank you so much.